Good evening, consultants and fellows of the call and colleagues. You are welcome to today's presentation. We are fortunate to have one of our consultants who has been helping us through our preparation over the period to take us through medical statistics, a guide to dissertation defense, and in the person of Dr. Kweki. So, sir, please, we are grateful for this and kindly you can start.
Hello, everyone. Good evening from out of West Africa. Again, my name is Tony, as you all know. Am I audible, Eugene?
Yes, sir, please, you are audible.
All right. So I want to use this medium to say well done to everyone since we started the discussion. I can remember that we started sometime in January, and it appears that we've made fantastic progress. We've been able to finish Brownward. And we are also on other aspects of the discussion. So that's great. Well done, Eugene. Well done to the team. It's our prayers that it will be a huge success at the end of the day. Yeah, so today I thought we need to start looking into our dissertation defense because it's also a huge part of the exam. We all know that for you to pass the exam, you need to pass cardiology, you need to pass the book, and then you have to pass the general medicine. I would really encourage all of us to give attention to these aspects because if you don't pass these three things, you will not have recorded to have passed the exam. So that's why we're going to look into dissertation and see how much we can discuss in respect of being able to defend our book. So just of the discussion is for us to understand basic statistics. We are not statisticians, or maybe some of us we are if you've done masters in that area, but generally speaking, we're looking at it from the perspective of our dissertation. So I don't intend to talk about everything in statistics, it's just to be able to apply some of the knowledge of statistics to defending our book. Just to give an overview, just to let you know that statistics is not really difficult. It's a bit simple, but could be very abstract and volatile. You learn it today, you can forget it tomorrow if you've not looked at it. So it's something that it's simple. We see that every day because we are able to make judgments. If you can make judgment about any situation, you actually applying the principle of statistics. Because the hallmark of statistics is for decision making, either as a person, for the government, or for any other person. So that's the basis of evidence-based medicine. All the guidelines that we talked about all the time, they are based on what they found, and whatever they found were subjected to the principles of statistics. So it involves everyday life. We need to deal with the phobia and lifetime practice. Even after the book, I can tell you that as you continue to make progress, we continue to make progress in our career. It's something that we continually engage in if you want to write paper. So something that is important to you, to us as professionals, including cardiologists. You don't have to know everything, or you don't have to even do everything. But if you have a basic understanding of statistics, it's going to guide your communication with your statisticians. You can request for what you want. When you communicate, you understand what he says, and you can suggest what you want. So it keeps the communication very interesting, and then it could give you whatever you're looking for. So at the end of the day, you're not leaving everything up to your statistician. Keep your mind open. I think where we do have problem is when we come to the languages or language of statistics, and these are some of the things we will look into and see how we can make them easy. So just want to give you a summary of what is statistics? Statistics is act of science, okay, is a kind of a science that involve data collection. Eugene, am I still audible? Eugene?
Yes, sir. Please, you're audible.
All right. All right. So it involves data collection, stroke organization, data analysis, interpretation for the purpose of decision making. I need to take that definition again. It's important you understand what is statistics. Statistics means data collection, data collation, data analysis, and data interpretation for the purpose of decision making or for the purpose of evidence so that we can act on that. So I've tried to summarize statistics using our dissertation so that we could have this understanding that your dissertation is actually application of medical statistics. Because the first thing we do really is data collection, which define the first phase of any medical statistics. The first phase, again, I said, has to do with data collection. After you collect the data, you have to collate the data, put them together, clean your data. After collating your data, you need to make analysis. After analysis, you need to make interpretation. So you see that in all aspects of our dissertation. And lastly, once you make interpretation, you need to use your interpretation, which comes under your recommendation for the purpose of decision making in practice, as the case may be. So, trying to approach medical statistics from the perspective of our dissertation. So if we go by these pillars of statistics, medical statistics, the first statement is data collection. I'm sure we understand the word data, what it means. And data are just raw information. It could be primary data, could be secondary data. Primary data, you go to the field and collect them directly. Secondary data, they're already there. You just make another analysis on it. So primary data are the things that most of us do for our dissertation because you need to collect raw data from the patient. So those are primary data. But once you come to things like meta-analysis, systematic review, those are secondary data. You are getting it from data that have been there before. Okay, so for primary, that's one way to look at data. Another way to look at data, you want to ask yourself, am I dealing with categorical? So data can be seen as variables in the sense that they can change over time. So you define them as variables, variation. They are subject to changes depending on a lot of factors. Okay. So the word variables now comes in. So at that time, once you classify them as variable, you can talk about categorical variable, discrete variable, continuous variables. These are some of the things that are important when you come to your analysis. But let's talk about data collection. That is the first thing we tend to do because you want to do something, you looked at it and said, I need to research about the subject in this area. And because you have decided to make a research in that area, you needed to collect data. And because you needed to collect data, you had to submit a proposal. So that's the first thing every one of us did. You submitted a proposal. And usually when you submit a proposal, you need to include your introduction, which include your background, statement of the problem, relevance of the studies, hypotheses, research questions, your general objective, and specific objectives. If just to explain that point further, that your proposal is the decision is what you said you want to do, the concept behind it, the reason you want to do it, the question you are asking yourself, which are the hypothesis research questions, and you go further to talk about how you want to do it. Now, I brought this in to just give us an idea. This is my work. I worked on the echocardiographical correlate of left atrial function index in hypertensive patients. You can see the first statement I stated heart failure, hypertensive heart failure patient. So I stated heart failure, I stated the problem. So once the background really, you talk about the burden of the problem, which we all did. I'm trying to bring all this because if you want to defend a project or your dissertation, you need to start discussing from the burden of the problem. So have that as your perspective. I've said that heart failure is a global problem, costing 26 million of people to be sick worldwide. But hypertensive heart failure tend to affect a lot of people, and this affect their economic productivity. So I've stated the problem. That's just what I'm trying to say. So the first thing you must bear in mind where you're about to defend your dissertation, what is the problem that you are looking at? You must define the problem you are looking at. Okay. Number two, once you leave the problem you're looking at, which tend to talk about your background, you must talk about how does this your work contribute to solving the problem. That's what you need to look to. That tells you of the relevance of the study. If you look at these things, I have said that left atrial function index, which is a very good measure of the left atrial function, is not routinely done in our environment. But if we can get some correlates, then we can use those correlates as surrogates. So there is a problem of heart failure. Hypertension is a major cause in the sub-Saharan Africa. Left atrial function index is a good measure of left atrial function, but this is not done routinely in the environment. But if we could look at some correlates, some systolic and diastolic function correlates, we could use that as surrogate. So I define the problem, I define the gap in being able to solve the problem, and I prefer solution to how the problem can be solved. So that's something you need to bear in mind when you are trying to look at your work. Moving forward, your hypothesis is also important. Remember that you define two hypotheses, null hypothesis and the alternate hypothesis. The alternate hypothesis is really your working hypothesis, what you are trying to say that you will solve. Okay, for instance, in this work I've just quoted, I'm trying to say that there is a correlation between left atrial function index and diastolic and systolic parameter. That kind of statement where I say there is a correlation is referred to as a working hypothesis or the alternate hypothesis. Okay. The other hypothesis is the null hypothesis, which I would say that there is no correlation between left atrial function index and diastolic as well as systolic function parameters. So the negative statement to what you are trying to achieve defines a null hypothesis. And in fact, that is what is really tested. Okay, so when you are trying to make your analysis and you do say that p-value is less than 0.05, you are trying to say that your null hypothesis should be rejected. You are trying to say that there is a relationship. At least you are accepting the working hypothesis, which is the alternate hypothesis. The null hypothesis should be accepted. But in situation where you have to, instead of you to have accepted the null hypothesis, but you reject it, that is referred to as a type 1 error. So the point I'm trying to say here is that you need to be sure of the hypothesis you are testing. You need to really be sure, what are you testing in your work? What are you trying to find out? There's always that thing you are trying to find out when it comes to your work. Okay, so like this, my work, for instance, what I was trying to find out is correlation between left atrial function index with systolic and diastolic function parameters. That was what I was looking for. So at the end of the day, I should be able to say, is there correlation or there is no correlation? Okay, so I will leave that. So we all know about objectives. The objectives are very important. Okay, so these are just all. So in data collection, that's what we do really. Data collection, you need to write a proposal, chapter 1, chapter 2, and chapter 3. And that include introduction, literature review, and the method. Under the method, your study design is so important. You know, you design your study, or you design the study you want to do based on the objectives. Okay, and you need to talk about your inclusion, exclusion criteria, your sampling method, technicality in terms of how you are going to do the work, and then your finances. So these aspects of our dissertation or proposal, now we're talking about dissertation because we're going for exam, but for those going in October, we're talking about proposal. So this your dissertation, this aspect is referred to as data collection. That's the point I'm just trying to make. This is data collection. This technicality that you put in place help you to collect your data, defining the work in chapter 1. Chapter 2, you are looking at literatures from other authors. Chapter 3, you are telling us how you are going to do the work, how you design the work, some things you are going to exclude, the sample size you are going to use, and the technicality that will involve such that the work can be correctly done. So these are just some discussion about study design, usually divided into two. It could be interventional, which most of the time we do randomized control trials for large studies. But it could also be observational. We could be observational just means you're observing the data, you're not intervening. So in the context of being observational, is either you are looking back or you are looking to the future, or you are looking at the data right now and getting something out of it. I'm sure most of us, we do cross-sectional observational study because we just collect the data from our patients, except for some individuals that tend to do follow-up study where you follow up the patient for after some time. All right, so after your data collection, when you have collected your data with your questionnaire and everything, the next thing is to collate them. That's where SPSS comes in, for those of us that use SPSS. And we go further to clean the data, because sometimes when you collect the data, you soon find out that there are some data that are not properly collected. Some data may skew your results in a negative direction or positive direction. So you need to clean your data. That's the time you need to meet with your statistician, and then you start discussing and finding a way forward for the best statistical tool to use for the analysis of your work. So you can see that after that, so when you have collected your data and collated your data, the next thing is to do analysis on your data, and could either divide it into two, into descriptive statistics or analytical statistics. So usually every one of us, the moment you have collated your data, you're moving into analysis, we must describe. So you describe in terms of the mean, in terms of the media, in terms of proportion, percentage, frequency table, and sometimes you can do cross table. So, and it does happen because no matter how the kind of work you are doing, you must be involved in describing your data. That's the first thing you must do. You must describe the data that you are having. These aspects may generally not be important in terms of your objective, but they're important in terms of describing your initial data, in terms of the mean, in terms of proportion, percentage, frequency table, or cross table, which I am sure every one of us we did in our dissertation. So the next thing is that once you've described your data, you're moving into analysis. And this is where most time we tend to have some difficulty. Like I said before, we are not statisticians, except if you have taken some special interest in that and you're building career in that area. But generally speaking, all of us, we are applying the knowledge of statistics in solving our problem. So these are the common statistics we do use sometimes, and it's important for we to understand, and I'm sure we're going to have a very robust discussion on this area. Chi-square is usually used when you are trying to look at a relationship between data. Like I said earlier on, that you look at data as variables, you could describe them, which is the first part. But when you begin to make analysis, it just means that you are trying to look at relationship between them, because you must subject differences that you're observing in your data to statistical tests. It is after you've subjected these differences to statistical tests that you are able to say that whatever you observe is significant or not. And the way to do that, we have different kinds of statistical tools. There are lots of them, okay? But these are some of the common ones we use in terms of our dissertation. And the truth is that the work you need to do really is to get used to whatever tool that you have used. So the commonest one we use is chi-square. Chi-square is just a tool that helps to look at relationship between two categorical variables, that is variables that cannot be represented in numbers. For instance, gender, okay? For instance, gender. If you're looking at hypertensive patient, for instance, and you divide them into male and female, then you want to look at the relationship. So they cannot be represented in decimal points, okay? You can only represent them in proportion, so, or percentages. So because of that, trying to look at a relationship between variables like that, we tend to use the chi-square. Another thing we also make use of is the odd ratio. Odd ratio, just look at the odds of an event occurring, okay? Comparing those that were exposed, those that have the disease and were exposed to the risk factor, and those that do not have the disease and were exposed to the risk factor. So you compare this group of people together. If you do compare them, it's going to give you a number. Is it more than one? Is it less than one? Okay, if it's more than one, it tells us that the odds of you having a disease is high. Less than one, the odds of disease is low. So these are tools that you use in order to define whatever variables you have. And the kind of statistical tool you will use depend on your variable. And because this is important, because if you use a wrong statistical tool to assess significance in your variables, it just mess up the whole world. It just give you a different result entirely. So it's important for us to really understand the concept of statistical tool. The other thing we commonly use is t-test. T-test, you're trying to look at the significant relationship between two continuous variables. In other words, you're looking at the relationship between two variables that can be represented in decimal places to make it easy for understanding. So it could be paired or unpaired. Paired just means that if you have, for instance, you're looking at hypertensive patient with heart failure or without heart failure, okay, something like that. Hypertensive patient with heart failure or without failure, they are paired. They are the same patient you've broken into two. Okay. So you're looking at, for instance, let's say you're looking at the weight or the height, the weight or the BMI of hypertensive patient with or without heart failure. The same hypertensive patient with or without heart failure, you are trying to look at the BMI, that kind of relationship where you test two variables that are continuous with a t-test is referred to as pair t-test. Sometimes you could also test two variables that are not really related. Let's say, for instance, you are trying to look at two independent variables. They are quite independent. You collected a different patient entirely, diabetic patient, okay, without hypertension. Then you now collected another patient, group of patients, diabetic patient with hypertension. So different group of patients, and you're trying to test a continuous variables like BMI or weight. So you refer to them as unpaired. They are different group of patients. They are not the same. They are different group of patients. Okay, so that's what we refer to as unpaired. That's when the t-tests become unpaired at that time. They are, another word we can use is independent. They are not dependent on each other. They are different group of patients. Another example is ANOVA. ANOVA is just means analysis of variance. This is when you want to look at different patients that are 3 and above. You know, t-tests tend to look at the statistical analysis between two variables. You are looking at two variables. For instance, hypertensive patient, diabetic patient. You are looking at the BMI. That's two variables. But if you have 3 variables and above, hypertensive patient, diabetic patient, heart failure patient. So these are now 3 variables. Okay, you are looking at the BMI in 3 group of patients: hypertension, diabetes, and heart failure patients. In that case, you can no longer use t-test because t-test is only applicable to 2 patients. So in that instance, you tend to use ANOVA. And usually after, again, like I said, you really don't need all this detailed knowledge except you have interest in statistics. But the idea of this is to really help us have a chat with our statistician, or you at least be able to defend and say something about the statistical tool that you use in your work. Okay, sometimes after you've done the ANOVA, it's able to give you a relationship between the 3 parameters. For instance, you're looking at BMI across diabetic patient, hypertensive patient, and heart failure patient. BMI among 3 of them, is it significant? You can use ANOVA tool. The good thing is that you can just pop this on SPSS or any other statistical tool and you can have a result. So once you look at 3 of them, you are going to have a p-value. So the p-value will tell you whether it's significant or not. If the p-value is less than 0.05, it means that it is significant. But if the p-value is not, it means it's not significant. So if you look at BMI among these 3 variables, hypertensive, diabetes, and heart failure, and it's significant, you must go further to subject them to the post hoc analysis. The post hoc analysis just asks this question. If I say that BMI across diabetes, hypertensive, and heart failure is significant, where do I have the significant? Is it between hypertension and diabetes? Is it between hypertension and heart failure? Is it between diabetes and heart failure? So where is this significant among these 3 group of patients? So post hoc analysis is able to tell you where it is, and then you could present it properly that the significant I'm seeing among these 3 people is across the 3, is across hypertension and diabetes, is across diabetes and heart failure, as the case may be. Okay. So the next thing is validity testing. Then you talk about your sensitivity, which I'm sure we know what it means, specificity, we know what it means, negative predictive value, positive predictive value. But of importance is the receiver operating curve. This is a diagram that helps to relate your validity on a graph, and you are able to have a number that help you to say this is it. SPSS will give you all this anyway. Correlation, negative correlation, positive correlation, logistic regression could be bivariate or multiple logistic regression. So logistic regression, really, we tend to use it when you are trying to predict whether a particular test can replace another test, okay? Whether there is proportion of using another test as a surrogate. So in other words, all the correlation you have that are significant, you can subject them to logistic regression to define whether you can use that parameter as an independent or those parameters as a predictor of your outcome. Okay, so that's what your logistic regression is there to help you with. Now, so it's also in the analysis, which is the chapter 4 of the work, because in your dissertation, chapter 4 is where you do the analysis, and that's what most of us were going to defend. To be honest, in the project defense, you are going to be doing two things. Number one, you did the work according to the approved proposal. That's one defense that you are going to put on. You must show to the examiner that I have done this work according to the proposal, because they have approved the work for you. You said, this is the proposal for this work. So they expect you to have done the work according to the proposal. It's like you made a proposal to a bank to collect a certain amount of money for a particular project. So when the money comes, you decide to use it for something else. So that's misappropriation of funds. So the same thing is applicable to our dissertation. You have said that I want to do this work. This is a concept. This is what I want to do. I'm looking in this area, and this is how I would do it. So any idea or any reason for you to have shifted from that proposal without properly communicating with the college or letting the examiner to be in communication, it is seen as breach of that proposal. And once you breach your proposal, it's a difficult thing. So, which leads me to the point that there are some things in the proposal you can never touch again. I sent a video earlier on the platform. I expect that we have listened to it. That was what we discussed some time ago. You can't change your topic. Your topic is there forever. You cannot change your topic. That topic has been approved, not just approved. The topic has been registered that this is the topic of this project. Any change you put on the topic just automatically says that is another topic entirely. That's not the topic you register. You can change your introduction, overview, you can write that again, but your objectives, you cannot change it, because objectives were the goals you said you are going to achieve in the course of this project, and they approve it. Like, you presented the proposal to them, you submitted it to them, they look through it, they approve it that this objective is okay for you to do. If you go back and change them again, it's a breach of trust. And it appears that you have not followed what you will say. So that's the reason they can fail a candidate. Literature review is usually not a problem. You can write it again, you can rearrange it. But when you come to your methodology, there are some things you cannot change. You can't change your study design, because you have said that this study, I am going to do it like this. And these are my inclusion and exclusion criteria. You cannot change those things. If you must change it, you must write back to the college for them to look into those things that you are changing. It's just like you have done a proposal to a company and that you're going to supply this model of so and so, and now you go to the market, you're bringing something different. So it's a breach of trust. So you cannot change your study design. You cannot change your inclusion and exclusion criteria. You can't change your sample size, because you said this is the amount of people I will collect. You can't go below it, but you can go above it, because the higher your sample size, the more the power of your study. So it's minimal. If you remember, whatever we calculate in terms of sample size is the minimum. So as long as you go above it, is not a problem. Then, as part of the method, you have also defined some standard criteria as per measurement. The standard you are going to use for EF, the standard you are going to use for TAPC, the standard you are going to use for whatever parameters you are looking for, you've defined it and you told them that this is what I will use to define this, and to define that. These are the things you cannot change because they were accepted as standard for you to do the work. So an attempt to change it is a problem. So the exam really, first of all, the first part, they're going to look at your proposal, which is now your dissertation, part of your dissertation, and see whether you followed everything you did. That's number one. Number two, they're going to look at this thing that you did. Do you even understand it? That's the question they're asking themselves again. So you need to really understand your work, not just the terms of the result, the terms of the basis of what you were doing. As I said in introduction, what is the burden? What is the problem? What is the gap that you have identified? How are you planning to solve it? You must be able to say those things without looking at your work. For instance, in that my work, I was looking at echocardiographic correlates of left atrial function index in hypertensive heart failure patients. What is the burden? Hypertension is a global pandemic. More also, heart failure is a global pandemic. More also, hypertensive heart failure is a huge problem because it tends to affect young individuals and this affects their economic productivity. So that's a big problem. I went further to say that if we could assess the left atrial function a bit earlier, we'll be able to prevent this from happening because if they have hypertension over time, they tend to go through remodeling, and the left atrium appears to be the first part of the heart that is affected in terms of the function before it progresses to have changes in the left atrium and all of that like that. However, in our environment, right now, we don't assess the left atrial function index. Can we look at surrogate? So that's the gap. That's the problem. We don't assess it. Can we look at possible surrogates like the parameters of diastolic and systolic function parameters to be able to give us an idea into the left atrial function? So that is my hypothesis. And I stated that there's correlation between left atrial function index and EF, or parameters of systolic and diastolic function. That was my working diagnosis. So at the end of the day, I subjected this thing to statistical test. So I did correlation. When I found a positive relationship between EF and E over E prime, I went further to subject it to logistic regression to see whether we can use EF to predict left atrial function index, as well as using E over E prime to predict left atrial function index. So you should have the background of your work in your mind and discuss it as something that you have done by yourself. So the next thing I would add again is that although we've submitted our table, it's always nice to arrange your tables in order of your aim. Of course, we all are going to do the descriptive statistics. After describing, we'll go further to do analysis. When you are trying to present the result of your analysis, it's always good practice to do that in the order of your objective so that the examiners are not looking for it. Because to be honest, the objective are the question for the exam. The examiner are going to mark the objective and be sure that you've answered the objective you said you are going to do. That is the first marking step of the exam. Okay, remember that they are with your book for 3 months before the exam. So they're going to settle down, go through it, and make sure that you've satisfied the objective in your chapter 4. So it's always good to arrange your objectives arrange your tables in order of your objectives such that your examiner can understand easily. But I'm sure this is for those going in October, because for those going next month, we've already submitted our paper. So be medical in your thoughts. I will tell you what that means. Don't just report data. Answer your objective. So the medical in your thoughts, I mean, something like social demographic characteristics of hypertensive heart failure patient. I try to avoid things like social demographic characteristics of study participants. That doesn't tell me anything when you use the words social demographic characteristics of study participant. Who are these study participants? So you rather use the patient you are dealing with. Okay, baseline characteristics of heart failure patient, atrial fibrillation patient, patient with pericarditis, patient with peripheral arterial disease, pulmonary hypertension patient. Use the patient. Remember that you are really dealing with issues of life that has to do with patients, so you present them. All right. So yeah, so this is another thing to also explain the point I was just trying to talk about. I said independent predictors of left atrial function index among hypertensive heart failure patients. I did not just say independent predictors of left atrial function index among the study participants. So you should be able to make it medical, state the knowledge in form of the medical caption so that they will understand. The same thing, correlation between left atrial function index and left ventricular systolic function. Okay, so that is everything about data analysis. Remember, I said statistics is a science that has to do with data collection, collation, analysis. So we've discussed the collection, which is basically our proposal. We've discussed the collation, which is SPSS or any other tool you are using to do your statistics. And thirdly, we said data analysis, which is our chapter 4. We all will do that. Then chapter 5, discussion is part of chapter 4 because you're not trying to discuss your results relative to other authors. And again, if you're doing your discussion, you can follow the pattern of your objectives. It makes your examiner to understand what you are trying to say. But if you just discuss all of them, I see sometimes people discuss age, height, socioeconomic status, and they've left completely their objectives. I am not saying that those things are not important, but keep a greater proportion of your discussion to answer your objectives. That is the exam. So the next thing is data interpretation. So once you're done with your data analysis, the next thing you move into is data interpretation. This is where you make meaning of your analysis. Okay, for instance, if I say that EF, ejection fraction, is an independent predictor of left atrial function index. What do I mean by that statement? So that's where you are trying to do your data interpretation. So under data interpretation, we usually talk about your conclusion and your recommendation. Conclusion and your recommendation. So your conclusion is also based on your objectives, okay? And your recommendation is based on your conclusion. So for instance, I started with my objective, which is to look at correlation between left atrial function index and systolic parameters such as ejection fraction. At the analysis, I found out that there was positive correlation between left atrial function index and ejection fraction. I went further to subject that to logistic regression testing to see whether it could predict left atrial function index. I found out that it was also significant. In other words, it's an independent predictor of left atrial function. So what is my conclusion based on these findings? So I can now make a conclusion that ejection fraction can predict independently left atrial function index. That is my conclusion. So you conclude based on your objective, because oftentimes I've seen where people make conclusion and the conclusion they are talking about is not even part of the objective at all. So along the way, there seems to be a drifting away from the initial thought of what they want to do. Remember that when we talk about objective, your objective must be smart. They must be specific, measurable, attainable, realistic, and time-bound. They must be specific. For instance, I said I want to look at correlation between ejection fraction and left atrial function index. It is specific. Ejection fraction, left atrial function index. This is specific. Okay. 2, it's measurable. I can measure ejection fraction. I can measure left atrial function index. 3 is attainable. 4 is realistic. And at the end of my conclusion, I am stating that yes, it did not just correlate, it was found that is an independent predictor of left atrial function index. So that's how it is. So you conclude based on your findings as a result of the objective you said you want to do. Once you have concluded, the next thing is to make recommendation. Recommendation is just like what we discussed, is guidelines. All the guidelines that we studied today were as a result of work that they've done in the past. So they had a conclusion and they are now recommending what should be done. For instance, they've tried high sensitive troponin. They did a study on it and they found out that it's very good to pick up a lot of patients with ACS. So they had that conclusion. So they now made the recommendation that every patient that comes to the hospital should have troponin done first 1 hour, within the first 1 hour. Some people say within the first 3 hours. So that is the recommendation they gave. So now that you have concluded the work, what is your recommendation? So in that my work, I made the recommendation that in a low resource setting, that ejection fraction can be used as a surrogate of left atrial function. So if you want to have an idea into the left atrial function, the EF could form a surrogate to that. That is my recommendation. It doesn't mean that they have to be put into practice, because you remember that before anything can be put into practice, a lot of findings will have to be put in place, have to be a lot of systematic review and all that before they will accept it. But based on this, your work, this is what I am recommending. Based on this, your evidence. You just have an evidence based on your work that you found this, and that's your evidence. And based on this evidence I have on this work, I am making this recommendation. So after that, we can talk about limitation, which I'm sure we all know. So this is what I'm just talking about, okay? But don't have time for that. So some tips on our defense. I know that we've discussed this extensively, and then we also have a chat about it. I can see that we have some other people on the call tonight, and then we can also discuss on this. So the first thing is that we need to be sharp, but not overdress. Arrive early. When I did my exam, it was horrible. Myself and Oladimeji were trying to sort out a lot of things that morning. Got a bit late. It could be very disturbing, running around looking for my venue in that Ibadan. It was crazy, going upstairs and coming down and all the stuff like that. But the point here is that arrive early so that you can be psychologically prepared. You're about to do a presentation of your own work. So present your work and put all the things we've said so far in place. Be sure that you have an overview of your work. I've discussed that extensively. Be teachable while you defend, but you must be reasonable. Remember that you want to be a consultant. It's not everything they tell you, yes, sir, yes, sir, yes, sir. Sometimes you need to explain some things to them. That this is what I did, this is the reason, especially when whatever you've done is based on fact. Present your fact. But if they still insist, accept what they're saying. Okay. After the defense, try to move to the next exam, because the defense tend to happen before, I think before the oral or general medicine. Yeah, it tend to happen before general medicine. And if you were destabilized on the day of the defense, you may not be able to put yourself together. So try and put yourself together and go ahead with the defense. I think I will round up here because we've been talking for a couple of minutes. The point here is that statistics is actually everything about life, and our dissertation is actually application of statistics. That's what I've been able to show to you. That dissertation has to do with data collection, which you have done, data collation, which you did, data analysis, which you did, and data interpretation for the purpose of decision making to the government, to those that are involved at lower level, and even to the doctors, to the other nurses and all the rest. So you present your fact to them. And it moves from that concept of collection, collation, analysis, and interpretation. So if you keep this perspective in mind, you'll be able to understand that statistics is actually application of the knowledge into your dissertation. Where we do have challenge most of the time is the data analysis, which has to do with a lot of statistical too. You don't have to learn everything, but you just have to be acquainted to the one you use in your work so that you can talk about it, because it's assumed that if you don't know it, how will you defend the work? You should have a statistician to help you, but it's expected that you guide him to get you what you want. Okay, so that's what I will say so far. I will now stop, ask for questions so that we can look at this topic further. Thank you. Eugene, over to you.
Thank you very much, Dr. Kweki, for such an excellent overview on how to approach your defense. We are very grateful. So at this point, please, let's unmute and ask our questions. And after this, I believe he will go into the components of the statistical analysis. Thank you.
Thank you very much, Dr. Wiki, and thank you very much, our leader, Dr. Eugene, for the great work you are doing. So, sir, please, I just wanted you to throw more light on that study design, throw more light on the study design, and then also throw more light on the analytic tools, what and what each of the two. Because I think for my study, I used the person's chi test. I also used the I think T test, student T test. So I would appreciate if you can throw more light on study designs, explaining why type of the study designs. I think my own was a comparative cross-sectional study. So I would appreciate if you can, break them down. Thank you, sir.
So thank you so much. Yeah, the first study design, yeah, from the words, how you design your study, is usually from the objectives. And we tend to have two ways that we deal with study design. Either you're doing an experiment, okay, or you are doing an intervention, and then you look at the outcome, or you are just observing the data. So you have interventional study design and observational study design. So when you observe the data, it's either you are going to many years ago, 5 years ago, to look at the data and see what happened. So a good example is you looked at people that have lung cancer today. You're looking at them, 100 of them that have lung cancer today. You went back to 5 years ago, take a history whether they were exposed to smoking. So that kind of situation where they have the disease and yet you are going back to look at whether they were exposed to the risk factor is retrospective, and a good example is case control study. Then it can also be prospective. It can also be prospective. Prospective just means that you are looking into the future with the study. You're trying to look into the future. So you collect patients that are smoking today, 100 of them, follow them into 10 years' time, and see what happened to them. Okay, let's see what happened to them. Will they develop lung cancer or not? So that's prospective. Then the last group of patients are the cross-sectional. You just pick 1, 2, 3, 4, 5, 6, 7, 8, 9, 100 patients and then study them. So which is what we do most time in our dissertation. Though some people do prospective, they follow up the patient for some time. But generally, most of us, we do cross-sectional. So which is what you've said you've done. You just cross-sectional mean take a cross-section of the patient and study parameters on them. So you took a cross-sectional of your patient. It could be heart failure patient, hypertensive patient, diabetic patient, whatever the cohorts or the population of patients. You just took a section of them and you decided to study what happened to them. You were not concerned about looking at the back or looking into the future. You just take what happened to them at that time, took their parameters, you're taking their blood, you're taking their history, you're doing their echo, you are measuring something from them. So that kind of study is a cross-section of a patient, which is what we do most times. So I think that's what you did. I'm sure that clarified that for you. Does that clarify that for you?
Yes, sir. Yes, sir. Yes, sir.
All right.
So I want to find out. So is it it's an observational study, right? Not a descriptive.
Observational study, yes.
Okay, sir. Okay, sir.
Mm-hmm. Then the other one is your statistical tool. Chi-square, we use that commonly because chi-square tend to look at the significant relationship between your variables, especially when you are dealing with categorical variables that can be represented in proportion. Okay? That's what we do most of the time. I don't want to go into whether they are normally distributed or not normally distributed. I will expect that any work we're doing, we should make sure that it's normally distributed. By that, I mean, when you say something is not normally distributed, you have to subject it to a test. And most times, because of you have one data that's queuing off the data. So that's the purpose of data cleaning. If you clean your data very well, it should normally be distributed in the population. But that's beyond this scope of discussion. But chi-square, remember that the purpose of analysis, you are trying to see if there's any significant relationship. That's what you're trying to look at. That relationship you were seeing in terms of your data. For instance, you are looking at a diabetic patient and you look at the proportional percentage, you realize that the female patient, they are 80 and the male patient are just 20. It's not enough to say, oh, female patient have diabetes than male. For you to be able to make that statement, you will have to subject it to a statistical test. And the test or the tool that you will use to make the assessment is based on the variables you're having. So because you're having categorical variables, okay, you have to use chi-square to do that, to see that relationship. 80 to 20 male to female ratio, that relationship, is it significant? That differences, is it important for you to say that patients that are female tend to have diabetes or not? So you subject them to a statistical test. So it is that testing. If the p-value, your computer will give you a p-value. If it comes down to be less than 0.05, it is significant. That relationship is significant. That's what you've just said. Okay? Then the other one is t-test. T-test is quite different from chi-square because t-test is using continuous variables that can be represented in decimal. That's the easiest way I just explained it. You could represent them in decimal. BMI, weight, height, EF, because I can do a 50% point. So most of the times in cardiology, because our parameters are figures and it could be represented in decimal, we tend to use t-test. So that's called the student t-test, which you have used. So once the variables are just two and the variables are continuous, then it meets criteria for t-test. So it could be paired and unpaired. I think we could leave all those details, but paired just means that you're looking at one population with two variables. One population with two variables, okay? You're looking at hypertensive with reduced EF and normal EF, okay? Hypertensive patient with reduced EF and normal EF. We are looking at the weight across them. Hypertensive patients, you divide them into subgroup, normal EF and reduced EF, or systolic impairment, diastolic impairment. Same patient divided into two. You're looking at things like BMI variable. You say it is paired. The same patient is paired patient. Unpaired is different patient. You have hypertensive, diabetic. They are two different people. So you're looking at the BMI across two of them. That's unpaired. So t-test could be paired or unpaired, but generally just the examiner must never bother whether it's paired or unpaired. So those are for the statisticians. Okay, any further question?
Yes, sir, please, sorry. I didn't ask on that one. Fisher's t-test, Fisher's exact test, please.
Yeah,
What is that
so
one for?
Fisher exact test. So most of the time when you are using your chi-square, all the criteria is that your cell, okay? At least if you have 20% of your cell is less than 5, 20% of the cell is less than 5. So usually if you do your cross table. Once you do your cross table, you remember you do your cross table, right? Hello?
Yes, sir, I'm here, sir. I'm here, sir.
Yeah. So once you do your cross table, you're going to have gender, male and female, okay? You have 1, 2, 3. So that'll be 2 by 2 table. So if you have 20% of the cell less than 5, you use Fisher exact test. You no longer, it's still the same process of chi-square, but you don't use the term chi-square, you use the term Fisher exact test.
Okay, sir.
So if you have 1, 2, 3, 4 as per 2 by 2 table, and one of the value is say 3. So 3 meaning 1/4. 1/4 is 20%. So if you're having one of them for 2 by 2 table, less than 5 is a reason to use Fisher exact test. Okay?
Yes, sir. Thank you, sir.
Thank you. Yeah. Any more questions, Eugene?
Charles has the hands raised. Charles, go ahead. So kindly unmute and ask your questions, please.
All right. Good evening, Chief Kweki. Good evening, everybody. Thank you so much, sir, for coming around to teach us these things. Thank you so much. We are grateful. I want to ask you to please, if you can expatiate more on logistic regression, okay, and odds ratio, because I know I have an issue understanding when it is you're supposed to use it. Okay, because or the suggestion advice, I use it in my work, but it's not so clear. It's not so clear to me. I'll be glad if we can make it clear. Thank you so much.
Okay, so the first one is odd ratios. Odd ratio, for those that do betting, they will know very well. You're looking at the odd of an event, or you're looking at the tendency of an event to occur or not to occur when they are exposed to the risk factor. some of these terms I like to use an example for it. That's how statistics a bit easier. For instance, you have 100 patients. You have 100 patients you are looking at, and these 100 patients you're looking at lung cancer in 100 patients, okay? So, and you're looking at 100 patients, and you're looking at those that have the risk factors. So you now realize that out of these patients, 20 of them had risk factors. 20 of them had risk factor and they have the disease. Okay? If you minus, so so 20 of them had the risk factor and they have the disease. So the risk, so 20 over 100, that would be like 20% of them. So you have another group of people. So 20 over 100 would be 20%. Then the other remaining 80%, remember, they also have the disease, but they were not exposed to the risk. So you can now see that you have some group of people that have the disease with the risk factor, some group of people without the risk factor, yet they have the disease. So what we usually do really is to compare people that were exposed and they have the disease and people that were not exposed, yet they have the disease. So that's how you compare the odds. But I think that what is so important for you to defend your work is that once you calculate the odds and the odds is a bit higher than 1, it tells you that the odds of the occurrence of that disease is high. That's what it just tells you. But if you now calculate the odds and the odds is less than 1, it tells you that the tendency for that disease to happen is low. So some of these things are very good if you can use figures to represent them, we calculate them properly. But that's just a simple way to explain I hope that is clear. If it's not clear, I'll pop up an example. Let me go further to the logistic regression. I'll pop out an example to make that a bit clearer in terms of using calculation, see whether that is possible. The logistic regression, okay, so in the case of the odds, you are assessing for a risk factor. Please keep that in mind. Once a patient, you are looking at risk factor. For instance, you are looking at risk factor, determinant of hypertension, determinant of diabetes. You are looking at risk factors, okay? Then the odd ratio become important because you are trying to calculate the odd of that patient that have that risk factor developing the disease. So if the odd is more than 1, it tells me that there's increased chance, probability for the patient to have the disease. But in terms of logistic regression, you are trying to predict an outcome. For instance, in the example I gave to you in my work, I had left atrial function. So I'm trying to use ejection fraction to predict the left atrial function because I don't have left atrial function index, which usually can do that for you properly. Now I'm trying to use EF to see whether they will predict that for me. So what I did first is to see whether there's a correlation. The only time you can go into prediction is when there is a positive or negative correlation, strong positive or negative relationship. There must be that relationship, either strong or positive. Either positive or negative, I mean to say. But it must be strong. So once you have that, you just put all this into SPSS. You are trying to use this parameter to predict the other outcome. For instance, I was trying to use the EF to predict the left atrial function. So if you are doing that for just 2 parameters, it is called bivariate. But if you are doing that for multiple parameters, like age, so you want to remove the effect of age, gender, other parameters, then it's called multiple logistic regression because the computer is able to assess each of those parameters independently to define whether they are able to predict that outcome. I hope I've been able to explain this the way you understand it. Charles?
Yes, sir. It's clearer. It's clearer. But my only confusion still is this statistical parameter able to predict the outcome in one sitting? Okay, for example, in my work, what I did was to assess whether um, uh, uh, right atrial enlargement, okay, is able to predict the occurrence of pulmonary hypertension. Okay, I also tried to access whether a tall R wave in V1 is able to predict the occurrence of pulmonary hypertension. Okay, and I found out that a tall R wave in V1 is like a predictor. But I still cannot, because they put the thing through the statistical tool and told me that it was significant. But I don't know, I have a problem wrapping my head around it to believe that that thing in one outcome is significant. I don't know whether you understand my question.
Yeah. So that's why when you look at study design, remember, if you are looking at level of evidence, you remember when we're looking at the guideline, we were looking at evidence A, B, and C, right? We classify them into A, B, and C. We also classify them into class 1, class 2A, class 2B, and class 3. So your study design define this level of evidence. So class 1 evidence are those randomized controlled trial, are those meta-analysis and all those stuff like that. But cross-sectional studies are put on the level of evidence. I think it's, I'm not sure of the value right now, but they are lower down. So your study design will define the level of evidence because it can't accrue so much evidence on just taking a patient within a short time and you are saying this is it. They can't really take that higher than a randomized controlled trial that look at these things over a long period of time. So it's just a level of evidence. And by the time you're doing cross-sectional, it's not so as powerful as someone that do prospective or someone that did intervention, randomized control trial. So the level of evidence are not the same. That's just the differences. But you can present that this is what I found. That's one, this is what I found. Another discussion is level of evidence, which is beyond dissertation. There's no way you can be following up a patient for 3 years. So, but for what you found,
it's clear, yes.
Yes, but it will be lower down as per the level of evidence. So they'll now start discussing it. Okay, is it class 1 recommendation or class 2 recommendation? They will now say class 3 recommendation. So it's not something we can use yet because the evidence surrounding it is not enough for us to be able to put that in clinical practice. So wait for more paper being written all over the world. When people are trying to do meta-analysis or systematic review, they look at the study design. They are looking at study design, your own is cross-sectional. They will just say, no, we were not looking for cross-sectional study design. We were looking for people that did randomized control trial to give us a very powerful study. You get the point I'm trying to make. But
I get the point. It's clear
as
now.
your work is valid, you defend it like that this is what I found. Then you state your limitations.
Yes, sir.
All right.
Thank you, sir. Thank you.
Yep. Thank you. Okay. Any more question, please?
Good evening, sir. Thank you, sir, for coming around to help us out with our dissertation. Sir, please, I have a few questions.
Okay.
And concerning, let me use my work as an example. So I had two sample size formulas, the quiche and the two proportion. The two proportion gave 192 as a sample size, and the quiche gave 180, and I used 180. Is there an issue with that?
So what did you say you will use? What did you submit as a proposal?
I submitted both on the proposal, both were there, like both the quiche and the two proportion on two of them were there. My assessors didn't say anything about the sample size formula, whether to choose any of them. So me on my own, I chose the quiche.
So if I understand you very well, you've calculated the sample size you use for the work, then you use two formula to get that.
Yes, like when I submitted the proposal, I had the sample size calculation using quiche. I also had the sample size calculation using two proportions.
Oh, I see.
That was
Is there any reason why you used it?
why I used the smaller one.
No, the two sample proportion calculation and the other one.
Okay,
Each.
my supervisor here said I should use both. Any one that is accepted by the college, that's the one I'll follow. But the college didn't say anything about the sample size. They just noted that it was okay. That was their comment. But I don't know which. They didn't choose any particular one. Let me
Mm.
use the.
So
So
you use the higher one.
I used the lower one, the 180.
The other one was what was the value?
192.
Yeah. So there's this is quite peculiar, to be honest. I've not seen this before. I've not seen this before where they use two sample size being calculated. But I would say that as long as they never had any problem with it, you're using what they approve, you shouldn't have any problem.
Okay. Then
Yeah,
sir,
so maybe what you have to defend is why the two. So you need to look at that concept and defend why did you use this? Why did you use it? Why did you not choose this one at the end of the day? You must have a reason for that. Yeah.
okay.
And it's probably not the best to say my supervisor said so.
No, 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 no. That one
Yeah.
is just based on
Yeah.
why I used it was because actually I was doing a study on pre-diabetics,
Mm-hmm.
and pre-diabetics are actually difficult to come across.
Mm.
So I had already the study was approved in March, and even as at January, as at December was when I finally. That's already almost a year just looking for sample size. So to now use 194 and wait for that, I'm just explaining that. So I just use the smaller, the 180. But of course, my supervisor said 180 is a standard sample size no matter what. So that it was okay, not like using 90 or maybe 60
I
or
think
something very
180
small
is good enough.
for that
Yeah.
population of people. Then, Chief, please, I want to ask a question about the sampling methods.
Okay.
If what's the difference between if you're doing a consecutive sampling, if
Mm-hmm.
you're using a consecutive sampling, because I noticed during the proposal, what I submitted was a consecutive sampling method.
Mm-hmm.
Then during the work itself, I still did the same, but I knew I could have used a randomized control, a randomized sampling method. But I didn't change it, but I was saying to myself, like randomized too could have been done for this based on the amount of people. That was not what was approved. So can I, if I go for exam and maybe they are like, you should have done a randomized sampling method, can I still say in my defense that I stayed with the consecutive because that was what was approved by the college?
Yes. Just stay with that one. Every one of
Oh,
us does consecutive anyway. As the patient are coming, are recruiting. That's what we do. So it's just stay with what was approved. Don't, even if you do randomize and all it, just stay with consecutive. Stay
okay,
with what was approved. They saw it and they approve it. Remember, they are also assess people, so they know that all these systematic we don't really do it.
okay,
So
okay.
as patient come, you recruit. As patient come, you recruit.
Exactly.
So stay with the consecutive.
Consecutive one. Okay.
Mm.
Okay. Thank you, sir. That's
All right.
all. Yes, sir.
Eugene,
Good evening, sir.
good evening.
Thank you for the lectures. Please, I have a clarification as regards my own citation
Mm-hmm.
because as part of the specific objective I set out, I didn't meet some of it. For example, my topics is actually burdens of atherosclerosis in hypertensive heart failure, and what I
Mm-hmm.
mean is peripheral arterial disease and coronary arterial disease in patient with hypertensive heart failure. And the tools that I set out to use was the Doppler ultrasound of the lower extremities
Mm-hmm.
and coronary CT angiography. But those
Mm-hmm.
coronary CT angiography is meant for only those people that have significant peripheral arterial disease
Mm-hmm.
on Doppler ultrasound as defined by greater than or equal to 50.
Mm-hmm.
But along the line, I didn't pick anyone that has up to 50.
Mm-hmm.
As such, I could not get the second objective, which was the prevalence of coronary arterial disease in hypertensive heart failure and peripheral and significant peripheral arterial disease.
Mm-hmm.
And the third objective was to look at the correlations. I didn't also get that. Now,
Mm-hmm.
in rattling around those orders, how do I go about it?
So yeah, just explain what you said. What you just explained now, explain it. Yeah, usually that's the problem with where you are having objective from the result of another objective. You get what I mean?
Yes,
So
sir.
you have just said the reason why you go for you are going to check the coronary arteries. Is it coronary arteries or carotid? You said coronary arteries.
No, coronary and periphery, the lower extremities.
Coronary arteries. That's the CT coronary angiogram.
Yes, CT, yes.
That's a lot of money. You had money to even do that. So the point, yeah,
But
you
I
didn't
didn't do
see.
I didn't do any. That's the problem. None
Yeah,
of
but
the patients met that criteria for me to
so
even do
if you
this.
stated in your method that this was, if any patient meets the criteria, I will do this. If you stated it clearly in your proposal or in your methodologies,
Yes,
there's
sir.
no problem. You stated it, nobody met the criteria. So the question you start discussing why? Why did they not meet the criteria? So what happened? So start discussing the patient I collected, So yeah, you must provide a reason why they did not meet the criteria. So it's a negative study. You didn't get any patient. You picked all hypertensive patients, atherosclerosis. For those that meet some certain criteria in atherosclerosis, I will go further to check their coronaries. I did not meet the criteria for atherosclerosis, so I did not check. Why? So you need to now you need to state why. What happened? Why did you see? Is it the age of the patient? Is but as long as you stated that in your method that this is what you're going to do and you followed it and you didn't see anything, I don't think it's a problem. But that
Okay,
will
sir.
be a part of your discussion. You should also discuss it. You should highlight it. They should not raise it before you raise it. You should
I
have
discussed it. I discussed it.
discussed it in your discussion, discuss
I
it
did.
in your
Uh,
conclusion, recommendations, and limitation and all that. So you should talk about it so that by the time you are talking about it, they know that you are aware of it. So that become a question for another person to do a study tomorrow.
okay, sir.
Mm.
Thank you, sir.
All right. Any question?
Okay, so we don't have any hands raised. So, Dr. Kwek, I don't know whether you continue with the second part you plan on doing.
No. I think I need to sort out some logistics around right now.
Oh, okay, okay. All right.
I was talking about that calculation, right? Is that what
No,
you mean by second part?
I thought you were planning on going to go a bit in explaining the statistical tools as part of this presentation.
I've tried to do some of them. Odd ratios, that was what was given challenge to Charles, which I wanted to just use some tables to do that, but Probably we could do that again because I need to sort out some logistics right
It's
now.
been very great, sir. We
Yeah.
understand. Very great presentation. On behalf of the group, we want to say a very big thank you for
Yeah.
making time to take us through this most important part of this dissertation defense. We are grateful.
Thank you.
We are
Thank
very
you.
grateful. God richly bless you and may you reward
Amen.
you abundantly.